All right, well, let's go ahead and get started. So we have time for questions at the end. And this is, today we're going to be covering, opioid use disorder and the justice involved populations. And we'll describe a little more about what that means. And we'll talk about some of the integrations, innovations, best practices, and then a bunch of other stuff in the middle of it. But before then, I'm going to let Serenity kind of just walk us through some of the basics of the webinar, getting CEUs and all that fun stuff.
Thank you, Corey. Hi, everyone. My name is Serenity Madison from Granite Wellness Centers. We are honored and grateful to have Dr. Waller share his expertise and presenting this series with critical information to support all of us working in the field with young adults, youth, and families impacted by opioid and substance use disorders. This series is brought to you as a part of Granite Wellness Center's Youth Opioid Response Project, funded by a grant from the California Department of Health Care Services. Granite Wellness Centers provide substance use disorder prevention and treatment services for individuals and families in Nevada-Placer and surrounding counties. Granite remains open and committed to serving our communities and those in need during this pandemic. We encourage you to visit granitewellness.org for information about services and resources offered in person, via telehealth, and online. And also just a reminder that you will receive evaluations after each session. And after the last session, which is today, we will begin to process your certificates. You'll receive 1 credit for each session, and also will receive all recordings of the entire summit after this session. Thank you.
Great, thanks, Trinity. All right, and again, I have no disclosures. So on the objective side today, we really want to focus on the epidemiology of addiction within the incarcerated population. We want to talk about how do we understand that so many people have this, and then how are we going to build this into treatment and evaluation of these people, and then really kind of walk through at the end. I hope you're able to talk about the risk, benefits, and alternatives to MAT for the incarcerated population amongst yourselves, and then even if asked by an inmate or a county prosecutor or judge or somebody like that, to really kind of understand why it's important and what we're going to do. Before we do get started, I'm gonna hit our little picture here again real quick. Now, I show you this only because we've kind of gone back to this picture a few times throughout. I want you to use your prefrontal cortex. I would like you to push this information into your hippocampus and your central bed nuclei of the amygdala. And if you get angry about something I say, I hope that your periaqueductal gray blocks some of that frustrating anger that comes from producing your own endorphins, and that you find value in this in your orbital frontal cortex, and that your lateral habenula creates the default notion for treatment in the incarcerated person, and that your corpus callosum allows the really imaginative side of your brain to talk to the more analytical Spock side of your brain, and then ultimately get you rewarded enough to have your ventral tegmental area and your nucleus accumbens bounce out a whole bunch of dopamine by the end of this. So that is as much as we're going to use this for this video, but I think it's important for you to solidify this knowledge and recognize that when we talk about stuff today, the origins of everything that we're talking about still lives in the neurons in the brain, and we know specifically where these issues are. And if there are questions about how to map this back to neurological origins, I'm happy to do that at the end. But mostly what I want to focus on is the issue that we're dealing with in the incarcerated population, and how kind of excited I am nationally that this is becoming more of a standard of care. And if you look at the numbers of incarcerated persons and what's going on, you can see why it needs to be. So if we look back in the 80s, we had about 41,000 people that were incarcerated for drug offenses. And throughout the late 80s and early and mid 90s, we had a lot of lock 'em up approaches to this, war on drugs, part 1, 2, 3, and 4. All of that basically got us to the point of almost 500,000 people incarcerated for drug crimes by 2013. So that is a significant upward trajectory. It has us surpass any country on the planet for this, which is not a reason to be number one. And when we look at who's in there and who's been incarcerated, about 65% of these inmates meet medical criteria for a substance use disorder and active addiction, and less than around 11% are receiving any treatment for their addictions while incarcerated. And this is significant, especially when we have identified such effective treatments and identification pathways. If we look at the 2.5 million U.S. inmates, there's, now, if we look at, even now, there's like 3.1 million, I think is when we totally look at it. About 1.5 million to 2 million of those suffer from substance use disorder. So that's a lot of people when we expand out to the entirety of the population. And there's another 458,000 inmates that had a history of substance abuse or were under the influence of drug and alcohol when they ended up committing the crime that got them put into jail or prison. So in the end, if you combine both of these groups, 85% of the people in the U.S. prison population meet criteria for either very high risk use of a substance or a substance use disorder. And many would argue that if it is the use of the substance that got you into the position to commit the crime, that ultimately you still meet for a substance use disorder. So extrapolating that can put us up to where the clear majority of people who are incarcerated have a substance use disorder. And if we look at 5 major cities that were evaluated, we found that 63 to 83% of the arrestees had drugs in their system at the time of arrest, with marijuana and cocaine being the most common. And one of the biggest issues is that once we release someone from jail or prison, in the first 2 weeks, they're 40 times more likely to die of an overdose, specifically an opioid overdose, than somebody in the general population. So think about this. The national figures show these, disbursement of millions of people who are incarcerated, with a large portion of those up to 85% meeting for a substance use disorder, and they leave, they're 40 times more likely to die an opioid overdose. If they specifically were informally incarcerated because of, if we just look at heroin overdoses, meaning instead of oral opioids combined with other things, and we just looked at heroin, they're 74 times more likely to die of an overdose within the first 2 weeks after release. And this is in the setting where the number one cause of injury-related death for people in total is overdose. And last year, the numbers that have come down through the CDC for 2019 showed 71 to 72,000 people died of overdose. And we're looking at this year possibly as much as a 20% increase, secondary to the prolonged isolation, the rapid release from jails or prisons for those with low-level offenses, but still with no treatment, and then having a lot of the treatment providers kind of have to decrease the number or volume of new patients they can see. So as we start to look at this, it's only getting worse during this time of COVID. And after the entire year of release, even after they've been out for a full year, their risk of overdose still is 10 to 18 times. And this is not 10 to 18% higher. This is 10 to 18 times higher. And so we have to really figure out how we identify these patients, how we initiate treatment, we stabilize treatment, and then make sure on release that when they have a re-entry pathway, that also includes the connection to ongoing treatment, or at least the pathway to get them there. But even without that, these numbers exist. So even if we don't have all of that stuff put together, we still end up significantly decreasing the total risk of death by a significant amount. If we look at those that recidivate, I mean, we have about a quarter of the individuals released ended up back in prison about 3 years, most of that for technical violations, which obviously includes possession of or use of substances. Yet, very few probation and parole, now this is going up, but very few probation and parole really have robust capabilities to case manage and or directly treat individuals who are in probation and parole, or in your case, also AB 109 in California, that have the ability to continue to get treatment and support on the outside. And instead, if they end up with a positive urine, they end up just getting reincarcerated for that, rather than having an increase in the veracity of their treatment. So if we add medication-assisted treatment, and specifically the two that were looked at for this were methadone and buprenorphine, we find a 61% decrease in overdose deaths after reentry, and 82.4% continued in treatment after release. That's pretty huge when you think about it, because one of the misconceptions is, well, if I treat them in jail or prison, and when they leave, then they're just going to stop that treatment and they're going to go on and do whatever they were doing. It's just not the case. And so when we track this down, we do find that over 80% still stay in treatment. And with that 61% decrease in overdose deaths after reentry, that is a massive decrease in mortality when we look at things that we do otherwise that are kind of ubiquitously provided. And I'll give you an example. So let's say if I have a person in VFib or VTAC, ventricular tachycardia, the heart goes into a rhythm that's going up and down. If I see that rhythm as an ER doctor, I would shock that patient. And if I shock them in that rhythm, I have about a 20 to 25% chance of cardioverting that rhythm back to a normal heart rhythm. And we think that that's a big enough thing that we end up putting these automatic external defibrillators or AEDs in like Burger King bathrooms, so that we allow for a perfect stranger to shock another random perfect stranger. And we think that's a great idea, and we're cool with that, which we should be, because it decreases the risk of mortality and outside arrest by about 10 to 15%. And so when we see that, that's a huge increase in the number of people who don't die from their disease, as compared to the addition of something like medication-assisted treatment, which we show a 61% decrease in overdose deaths, yet we still have people fighting tooth and nail against the utilization of this in this very high-risk population. So some of the myths that continue to flow through this, the entirety of all of this is, that we're just replacing one drug for another. Or unless there's a full continuum of care in the community, I don't really want to start treatment while in jail, because then what's the point? And we said what the point was is they continue after they leave. And then they say, well, we shouldn't start medication if we don't have behavioral health to accompany it. And or we can't start MAT because of risk. And I hear all of these, and there's 1,000 other excuses that I hear on a regular basis. So let's go through these, and then I hope during this, if you have other things that are barriers for you, or you find are reasons that you feel you're unable to do that, please use the question and answer section on this and put those in as we go, and I'm happy to answer to those using the data science and math that we have, not just hyperbole or opinion. So one of the first things is we have to recognize when somebody says we're just replacing one drug for another, just on its face, that's not accurate. So first of all, if somebody has an opioid use disorder, they have at least 3 of these aberrant behaviors that are occurring. And that could be that they're using opioids in larger amounts, unsuccessful efforts to cut back, excessive amounts of time spent obtaining. You could have the social impairment pieces, failure to fulfill your major roles, persistent social or interpersonal problems, reduced or given up other social or occupational activities. You could have the risky use piece where you're using it in physically hazardous situations, or you continue to use it despite knowing that you have significant harm or risk. And if somebody injects heroin, basically you get all the risky use because it's physically hazardous, and you definitely have a risk of overdose, which is persistent physical. And then the craving to use is what drove you to get there. So it's really tough to get anything less than 3 to 5, getting us that moderate opioid use disorder. And then you have the pharmacological properties, which means you have tolerance to the substance and you'll have withdrawal if we stop it. So this is how we define opioid use disorder. So if I have someone who is using heroin or oxycodone or a combination of those, or quite honestly, alcohol or methamphetamine, that's the same general construct of diagnosis, the behaviors that they exhibit during that use are so consistent and so predictable that we've been able to whittle it down to 9 behaviors and 2 physiologic phenomena that we use to determine if somebody has an opioid use disorder. Now, if I give someone buprenorphine and I write a prescription for that and they take that prescription as prescribed, they no longer meet the criteria for opioid use disorder. They meet for opioid use disorder in remission, is the terminology that we use. They don't actively have it. They are in remission on opioid replacement therapy. And because we define addiction based on aberrant behaviors, if those aberrant behaviors go away, then it doesn't matter if they have the substance in their urine or not. This is the issue that we have to grapple with from a lot of things. What about if somebody showed up to the office with no history that you know of, and you see it and they have alcohol in their urine or on their breath? Does that mean that they have an alcohol use disorder? No, it means that they have alcohol in their system. You have to determine whether or not the use of that alcohol has created behavioral changes enough to push it toward what we find here on the diagnosis of the use disorder. So if I give someone methadone or I give someone buprenorphine, I am giving them a substance that decreases the chances of these behaviors occurring. And because of that, that is not replacing one drug for another. It is stabilizing a disease that is defined based on behavior, not based on the presence or absence of a drug. So when people say that, it's just that they don't honestly understand how to define the disease of addiction, because it is not just having something in your pee. All right, so unless we have the full continuum of care in the community, we cannot start treatment while in jail. All right, so I bring the slide back. We've already looked at this once. I want to look at it. I want you to look at it again. Is there any community in the country that you are aware of that currently has the full continuum of care for addiction at capacity? Meaning they have enough slots for everybody who wants care. No, nobody. It doesn't exist. And if you look at rural and remote communities, and you're out in, Placer, Nevada County, where you're much more rural and remote in some spaces, and so in that setting, it's going to be difficult or maybe impossible for you to have the full continuum of addiction care, from level 1 to intensive outpatient to partial hospitalization, residential treatment, or level 3.5 or 3.7, or even in LA County, we identified that they were missing a level of care for addiction, level 3.3, which is the addiction treatment for cognitively impaired or brain injured. And so even in one of the largest counties in the country, it doesn't fully exist. So just because it's not perfect or it doesn't fully exist does not mean that we can wait for something like that to happen when we have people dying at 40 times the rate and 74 times the rate of the general population with the disease. So we need to make sure that we're not letting our own preconceived stigmas and frustrations get in the way of doing this, because quite honestly, this excuse doesn't hold water when we look at what medicine by itself can do. So if we look at, we should not start medication if we don't have the behavioral health to accompany it. And I'll also hear, well, why should we start the meds if I can't get them into the continuum of care? All of this still kind of falls back on these pathways. So if you look at the data, what is the thing that shows an improvement in the patient's survival? The only thing for opioid use disorder that has shown a decrease in mortality rate over 1 year is the utilization of buprenorphine and methadone. Even naltrexone, in two large population studies that were recently done, did not show a decrease in mortality rate. And so this is a real issue, in that if we hold off on the meds and think, well, let's just talk to somebody and do cognitive behavioral therapy and mindfulness-based cognitive therapy, while some of their functions may improve, we're not changing their mortality rate. So increased retention and treatment. Medication is the only thing in the first year to show an increased retention and treatment when they do side-by-side trials. If you want to decrease illicit opioid use and other criminal activity among people with substance use disorders, that's MAT. So that actually is not just bup and methadone. That's all three: naltrexone, buprenorphine, and methadone for that one. If you want to increase the patient's ability to gain and maintain employment, then you need the combination of MAT and behavioral health, because the meds just by themselves didn't do that. Behavioral health by itself for opioid use disorder didn't do that. A combination of the two did. And so what about improvement of birth outcomes among women who've had substance use disorders and are pregnant? Now, we've had this conversation and we talked about that last time. This is important because MAT by itself still improves birth outcomes, and MAT plus behavioral health also does. So it just depends. If you only have MAT, don't hold that back just because you don't have, the whole thing, right? Don't let the enemy of good be perfection, because we know that the utilization of medication for the treatment of opioid use disorder improves survival, retention in treatment, decreases criminal activity, improves and helps to stabilize employment, and then definitely improves birth outcomes. So when we start to look at this, we have to keep in mind waiting for perfection is going to continue to kill people at a disproportionate rate. And as we look at this, it's actively happening at a disproportionate rate to those of color, because of the way in which we have identified and begin to incarcerate persons of color at a disproportionate rate than we do others. So this is definitely a part of that structural racism continuum, and the increase in the mortality rate that's disproportionate to one group or another. There was a question that came across about would you suggest someone begin medication-assisted treatment even if they've been incarcerated and staying, quote, clean or in recovery without it? Well, the answer is it depends. So if you have someone who's been incarcerated, recognize that in jails and prisons, drugs are available. And in many jails and prisons, drugs are just as available as they are on the outside. They're just more expensive and in lower amounts. So if someone has been able to maintain the being in recovery while still having access to drugs, they may not need medication. The key component that you have to answer is, are they having to hold on with their fingernails, and are they sitting in their cell and hiding because of the craving, because of the desire, because of this, and it's causing any of the other diagnostic pieces? So that's the piece. And one of the biggest issues with this is we don't do a good job of screening and asking these questions anyway. And we don't do a lot of urine toxicology screens to follow up on somebody we're not going to put in treatment. So we may assume that there are a lot of people who are not using while incarcerated. But when we actually start doing systemic drug testing, we identify that that's not the case. That the vast majority of people that have an existing substance use disorder will continue to use substances while incarcerated. And it'll just line up with what substance are they able to get a hold of. So sometimes it's alcohol, sometimes it's methamphetamine, sometimes it's heroin. It just depends on what's available. But in all of the research to date, which started in Rhode Island and is now expanded out to a large number of different locations, including in California, with 32 jails implementing this now for at least continuation, and many of those looking at initiation. And in the California Department of Corrections and Rehabilitation, I'm running a grant to implement addiction treatment there. And we have over 3,000 inmates on MAT that we started this year. And so what we're identifying as we start to lean into this space in that large population is that those who, were purportedly clean or in recovery actually weren't. They just hadn't been found to be positive because they were still having overdoses in custody. They were still having people show up and be intoxicated, and injuries, and then extra fights, and then the drug violence that goes on. And there are a lot of really interesting components that are happening throughout the country in places that have pushed all of that out. And the people that have put that out there ultimately have found that at the beginning it was a little bit of chaos as they stabilized the program. But then once they stabilized the program for those that had been incarcerated, and even those that are lifers, once they started it, they saw that there were less people, there was less violence, there was less selling and using of other drugs, and they found that the diversion of the buprenorphine that they were using went significantly down to almost nothing after things had stabilized. So starting it on someone who is, quote, clean or stable really depends on if they're able to maintain it, great. If they're not, they're still going to be at risk for overdose. But before we figure that out, you got to do deep screening and assessment. It's a good question. So the other one that comes up a lot is the we cannot start MAT because of risk. And this one is interesting to me. And if we look at these cases here, Pesky versus Coppinger in Essex County, and then Smith versus Arstook in Arstook County, and Smith versus Fitzpatrick, Courtlever and Wadham, and then DePiero and Hurwitz. When we look at what they were coming after, these were all lawsuits coming from two different angles to say that people with an opioid use disorder should have access to life-saving medications. And so one of the angles that was taken was the Eighth Amendment, and that they stated that the not delivering medications to stabilize opioid use disorder, it was found that it was a violation of the Eighth Amendment, and this, I mean, prohibits cruel and unusual punishment. So the reason being is that if you have someone who is having craving and mood disorders and destabilized thought disorders and continually seeking out drugs as a part of the disease of addiction, it's cruel for them to have to continue to do that while we have medication that can help to stabilize that thought process and then deliver the therapies to help increase the function. But also we were having people going into jails and being transferred to prisons who would be, you know, allowed to go basically cold turkey in withdrawal and have to suffer through that with maybe a cough medicine or a nausea medicine, which is not the standard of treatment for opioid withdrawal. The standard of care for treatment for opioid withdrawal is very specifically, you give them buprenorphine. And that's in an emergency department, in an inpatient space, in an addiction treatment facility, because in 10 to 15 minutes, it's completely gone. And now you can have the discussion of whether or not you would like to go from withdrawal treatment to maintenance treatment for that medication, or flip to methadone, or identify that you need to take a little longer on an inpatient stay and move them over to naltrexone. And we can talk about each of those meds and the pluses and minuses for those if we get to that point. So basically on this slide, you should understand that it has been found in a court of law that it is a violation of the Eighth Amendment to withhold medication for the treatment of opioid use disorder. And that's legal speak coming from a doctor, so take that for what it is. And then we also have Title II of the ADA, which was the other angle that was taken in the setting. And basically they alleged that failing to provide MAT deprived the plaintiffs access to the medical programming on the basis of their disabilities, which is in violation of the ADA. This one had state and local applicability, where the other one had federal jurisdiction applicability, prohibits discrimination based on disability, and specifically called out opioid use disorder, and that they showed that the person's right were violated when the person had the disability and were denied the public entity services or programs or activities because of that disability. And so this is a big issue that we're identifying. So keeping in mind that just saying it's risky to start the medication, it's really not, especially when you compare it to the lawsuits that are just going to be coming down the pipeline, especially now that there's already common law on the books. Another thing came up, said, how long do you have to wait after administering Sublocade to administer Vivitrol? So just to jump on that one real quick, Sublocade, generally speaking, is in the system for about 30 days. So typically you need to wait for 35 to 37, because even though it hits that peak dose, it tails off, and we don't have perfect answers. If you wanted to wait until it was for sure out of the system, it'd be 45 days after last dose. And then you can still do a urine tox screen to see if you're still finding positive bup in the urine. All right. So we've talked about these myths. So let me go back to these and we'll walk through it. So the myths, we're just replacing one drug for another. My hope is that you understand that that's just not the case. We're treating the behaviors associated with the disease of addiction by utilizing medication that decreases craving and stabilizes the mood in association with obtaining and using the other drug. So we're treating the behaviors. Second, unless there's a full continuum of care in the community, we can't start treatment in the jail. That's just ridiculous. That's political speak for I don't want to start it. It's not something that is even really doable for the next decade. And we should not start medication if we don't have behavioral health to accompany it. We've shown that through a number of different avenues that the medication by itself, even without good behavioral health input, still decreases mortality rate and still decreases criminogenic behavior. And, of the populations that I treat, behavioral health is needed. They have deep trauma, as we've talked about on a couple of lectures ago. They generally have mood disorders associated with this in a co-occurring modality. And then when you start to add all of these pieces together, it becomes really an issue with them for long-term stability. But the medication by itself can be given and decrease mortality rate. And I think that's what we want to make sure we don't miss, is that opportunity to decrease that. And if we go to how do we do it? So this is always the big question. I get the question of, well, I'm a small jail here, or I'm a large state prison system, or whatever. We've worked in all of these places. And so let's walk through the basics. So first, in order to identify who you need to treat, you have to screen. And you have to screen and assess. So that means you have to do a screening for risk. And that's the NIDA-4, the National Institute on Drug Addiction, 4 questions. In the last 30 days, have you used an illicit substance? In the last 30 days, have you had more than, if you're a male, 5 drinks at one time or 14 drinks in a week? Have you smoked nicotine? Have you used marijuana? If the answer is yes to any of those questions, then you go to the assessment. Because the screen just says they have risk. It doesn't say that they have the disease. So you have to go to the assessment, which is the one that I always recommend is the ASSIST. And this is because it's a World Health Organization document. It's been validated in multiple cultures, including indigenous populations and many others around the world. And it's all the stuff is available in different languages, and that it sits in every electronic health record. So it's an easy one to get to, and it works. You use that one to identify if they have an actual diagnosis of addiction, and if so, how severe is it? And then the COWS for opioids, the clinical opioid withdrawal scale. And so the clinical opioid withdrawal scale is what we generally use to identify the presence and severity of opioid withdrawal. And if it's above a certain number, then we can start medications. And I'll dig in on that a little bit. But this is really important because this doesn't happen that often. Most jails don't screen for the presence, screen or assess for the presence or severity of an addiction. And this can be done at so the screening part can be done at booking. The assessment can be done, right after arraignment. I mean, there's a lot of stuff a lot of places that this can fit in the value stream of identification and treatment of these individuals. So it's not that you have to beef up a whole bunch of stuff. You just have to add it in there. The NIDA, again, is 4 to 5 questions. The ASSIST, depending on how many substances they use, can be anywhere from 8 questions to 36 questions. But usually you answer what you need to get done within 8 to 16 questions. All of those together take only a few minutes to do. And they could be broken up and done in different locations that they're there. Both of those tools were designed to have lay people be able to use them and deliver them as long as they do to fidelity. So in theory, you could even have custody do the NIDA and the ASSIST if they're trained on how to administer it, because they're not having to interpret it. Each thing gives a number score, and then that number score can be given to a nurse practitioner, PA, or physician in order to decide what needs to happen. And with that number, you would know right away whether or not you needed to start medication-assisted treatment, which can also be another algorithm. So one of the first things that we always tell people is that the thing that's going to rapidly decrease your risk from liability the quickest is to at least continue medication-assisted treatment if it's already started. So if they show up and they're on buprenorphine or methadone or naltrexone, continue it. Don't stop it. And you may have to change how you dose it or where it is and those things, and that's going to be up to the provider that delivers that care. But ultimately, you need to continue it in order for them to maintain their stability. And if you stop it, I mean, one, that's just kind of mean, because now what you're doing is automatically increasing their risk. You're taking an action that is increasing their risk of death by a significant amount. I don't know how it's not ethical in my mind. It's not moral in my mind. It's malpractice from a medical standpoint to purposefully increase somebody's mortality rate by stopping an effective treatment. So this is, I have a hard time with this one because there's really no argument from a philosophical, from a science side, from a legal side that makes sense on this one. The only one that it makes sense is on the stigma side and the discrimination side. Those are the only two places where I've identified that people can come from this argument. They're still wrong, but because all the other stuff stacks up, but at the same time, this is just something we have to do. And it's not a matter of if we do it, it's how we do it and how we stage it and who's responsible and how it gets as a part of the next procurement. I mean, I recognize that all of these things are a part of it. But for those of you who administrate care, you should just recognize this is an inevitability that it's going to happen. And it'll either happen because you lose a big lawsuit or somebody dies or both, or you just know you need to do it and it's going to get done. So either way, figuring out how you're going to set it up becomes important. And we'll talk a little bit more about that. The methadone can be a little more complex in this setting because methadone, if they're on it, if you don't have a methadone clinic or what is also known as an opioid treatment program or a narcotic treatment program, depending on which rules and regs you read. If you don't have one of those that you can partner with, meaning that if their patient shows up and they're on methadone, then they'll deliver those doses to the jail so that they can be dosed appropriately. It's pretty difficult. So a couple of pathways for that is one, you can talk to a methadone clinic in a remote location. And then you can have any patient that shows up on methadone automatically flip over to their service. And then you can become a remote dosing location in which they can deliver medication to you, and then you can deliver medication to that patient. Two, you can fill out the paperwork to become an opioid treatment provider or a registered licensed NTP. So you store the medication on site and you have a series of checkboxes that you get by for Joint Commission or CARF that do the accreditation along with SAMHSA and the DEA. The interesting thing with this one is that if you are dispensing the medication, because you're not prescribing it at that point, you're dispensing it. If that's the case, you don't have any limits on the number of people that your provider can use for either methadone or buprenorphine from the federal side. And so you'll have to look at your local regs because sometimes the local regs will put limits on number of providers per patients, but generally no jail is going to ever get close to that. And even within the prisons, because they're broken out and they have enough providers, they're not going to get to that. So this is what we're looking at for the larger systems, is to just have them legally become opioid treatment programs or narcotic treatment programs so that they can then dispense those medications internally. And then you're not limited by the X waiver ceiling. And again, to remind people, in order to write for buprenorphine as a prescription, you have to have an X waiver. And if you are a PA, a nurse practitioner, a physician, and a number of other APNs, advanced practice nurses, you can take an 8-hour course if you're a doctor, get an X waiver. And then, or if you're an NP or a PA, you can take a 24-hour course and get your, quote, X waiver, which is just a little mark on your DEA license to know that you can do it. If you're a physician, you can immediately write for 100 patients. And if you are board certified in addiction, you can immediately write for 275. If you are a PA or nurse practitioner, you start at 30, and then in 1 year, you can go to 100. All of those are petitionable, meaning that if you have a single provider and you need a higher amount because you need that, but you can't hire another provider, you can petition to SAMHSA and the DEA to allow for you to see more. Interestingly, most jails and prisons meet for a qualified practice setting. And a qualified practice setting means that it's not just somebody writing for the med, but you also have some case management, some behavioral therapeutics and nursing that is there. And if you qualify for that, even if you're not board certified in addiction, you can go up to 275. All of this is available on the DEA diversion website or on SAMHSA's website. Just type buprenorphine X waiver and you'll get all this information. But it is important to know that all of that goes away if you become an opioid treatment program and you're dispensing the medication. And we're working with the federal government right now to try to streamline the licensing, the federal licensing architecture of jails and prisons so that it can be done more rapidly rather than having to go through the same rigmarole of paperwork for a clinic that sits out on a community. Naltrexone, you can continue that. Now, if they come in, you can continue that with oral naltrexone. So most people will get naltrexone. You may know it as Vivitrol, which is the long-acting injectable, but there's also oral. And if you use Vivitrol, then you could just dose it every 27 to 30 days as an injection in the butt. And please don't give it in the deltoid. I've done a lot of reviews on people who have not read the insert and actually given it in the wrong muscle. Not helpful. So when you do this, continue that. If it's working for them, great. If it's not, don't worry about switching. This is the thing that's very interesting is we seem to have some emotional contextual issue with which medication. And I've heard people say, I don't like methadone or I don't like, buprenorphine. And I'm like, I don't care. Why do you even have an emotional thought about a medicine? It's not like we sit around and talk about calcium channel blockers and they're like, oh, those calcium channel blockers freak me out, or oh, penicillin, hate that antibiotic. Nobody has that emotional connection. That's just stigma. And it's pretty unabashed stigma, especially since methadone is the highest treatment positive effect on opioid use disorder. Buprenorphine is right behind it. Naltrexone is helpful, but it has to be in the right population, and that is a motivated population that has been able to handle craving in a better way and doesn't have a significantly centralized depletion of dopamine. I've used all of these meds on a number of patients and feel very comfortable with all of them and use them when they're needed. It's just you have to pick the right patients for the right medication. If you are going to use buprenorphine, which is the easiest one to use inside of both from a cost standpoint and a delivery standpoint, and you're going to initiate someone on it or do what we call an induction, I will give you the two mantras to think of. The 888, which is if they have a COWS or a clinical opioid withdrawal scale score of 8, then give them 8 milligrams. An hour later, give them 8 milligrams. Pretty easy. 8, 8, then 8. Or if you don't want to have to wait the hour, wait till they're at 8 on the cows, give them 12, send them back to the cell. You're fine. People are like, well, that might cause precipitated withdrawal. By the time you get to 12 to 16 milligrams, 99% of withdrawal is abated in patients. We generally will only need to use 8 in the emergency department if we have someone come in and, florid precipitated withdrawal after getting naloxone. And the only dose that's been shown to significantly decrease illicit substance use is 16. So people say, well, that's a high dose. It's actually the only dose that's shown, to decrease the chances of somebody using heroin or using other drugs. So just match the data. Stop having an emotional feeling about how we like to or wish or hope. It just needs to, let your inner Spock flag fly, man. Just let it ride. The data is the data. And if it was 4, that would be awesome. It's just not. It's 16 milligrams is the dose that it is the most effective initiating dose. 8 to 12 milligrams in people in the outside community is the dose for long-term maintenance that seems to do the job. I don't know if it's higher or lower at the end of the day inside of the incarcerated location because they're just different pressures. So in the community, you can go hide at grandma's house most of the time. If you got to get away from people, you can just go somewhere and hide. But if you're incarcerated and you're in jail or prison and somebody in your yard is the shot caller and they're like, you got to use this drug or I'm going to stab you in the chest, you're going to use a drug, or you have to divert your meds. They're going to try to divert their meds, or you have to, take my drugs or, keep buying them or that. I've had people on Vivitrol still doing heroin who tell me, look, man, I don't get anything from the heroin. I only buy it so this guy doesn't cause me any trouble. So there are issues in prison and jail that are just very different from that. And so I would say that as we start to add these treatment cycles into jails and prisons on a more frequent basis and people are more comfortable and well-trained, that we need to make sure that we take a trauma-informed approach. Remember, we talked about that if you've been on the other webinars, that trauma-informed approach becomes really important because you need to not put intent on the decision. You need to, again, flip it and ask, what happened to you? Not what did you do? So this is a real issue with training and teaching custody, making sure that they understand that there are a lot of other pressures that are there. It could be as simple as you give them their dose in the morning and maybe they don't sleep well at night and they have nightmares from their PTSD and they would rather take it at night, but you don't have dosing nurses at night, so they're trying to hide it so they can take it at night. I've seen that. There's not always nefarious intent. And I know that's not our default place to go to, but we have to start thinking in a different pathway if we're ever going to get past this. So the piece that I want to spend a little bit of time on is the recognition that in our society, there are a couple of populations that have the highest propensity and risk for having an opioid use disorder. And one of those is our jails and prisons, and the other one is the emergency department. So if I had to choose only two places where we identified and treated patients, it would be those two places. Because when we said that over 80% and up to 85% of people that are incarcerated either have super high risk use of substances or a substance use disorder, there's no other place that has that density. There's just not. So when we look at the Pareto curve, which is, aka kind of the 80-20 rule, you get the most bang for your buck for going to the right place. And after you go outside of the emergency department or the jails and prisons, you have diminishing returns on the general population. If we consolidated efforts into jails, prisons, emergency departments, and associated structures, then we would have the ability to hit a huge number of people with very severe disease who also happen to have co-occurring illness and deep-seated trauma that sits within this. So keep in mind that you can make the biggest dent in your community of recalcitrant criminogenic behavior, of overdoses, of domestic violence, of other aspects of crime and risk and total cost by attacking those two populations. And if you just explain it to the people in the community, because I've heard people in some of these communities like, well, I can't even get treatment. Why is that dude in jail getting it? Well, the answer is because that's more likely to cause a positive effect on the community if we treat that person, and have a higher chance of decreasing the total mortality rate in the community just by identifying those highest risk groups of people. And so you want to use the least amount of effort to the maximal benefit. And that is absolutely what the Pareto curve teaches us from a number of aspects, but specifically for how we treat this and what we do. The utilization of medications for the treatment of opioid use disorder is just the standard of frickin' care. It's the standard of care. That's it. It's it. I mean, it's just, there's no question about it anymore. 5-10 years ago, I remember people arguing back and forth. They're quote, not clean. They're not this. The data is overwhelming. Thousands and thousands and thousands and thousands of patients that are included in these studies, especially when compared head to head with, going through a different route without using medicines. Clearly, there's a massive mortality benefit. Clearly, there is a massive benefit in maintaining retention and treatment. Clearly, there is a massive benefit in criminogenic behavior. Clearly, there is a massive benefit in delivering healthy children to term. Those are just settled issues at this point. Now what we need to do is figure out how we put this into the places with the highest risk populations, how we do it in structures that are generally overwhelmingly underfunded, that are generally maligned and have their own stigma associated with them. But if we do this and we pull it together and get to that place, then we're gonna have the capacity to help the most people that have the highest potential for the most harm. This also decreases the legal risk to any entity, whether that be probation and parole, whether it be a jail, whether it be a prison, or a community at large, by actively treating those with the highest risk. You're going to decrease your chances of having a lawsuit concerning the Eighth Amendment or a lawsuit concerning ADA, which are just going to start stacking on top of themselves. So we have to start thinking, especially now with these rapid release pathways, where somebody is, where we're doing the right thing, where we're incarcerating less people and we're decreasing volume, that not only do these programs have to live in the upfront, but they need to be deeply embedded in the diversion programs. If we're not going to have somebody in a controlled environment, then we need to make sure that they get appropriately matched to treatment. And kind of at the end of it, it is just the friggin' right thing to do. I mean, there are very few things that, one, are cost effective, that decrease mortality, that improve livelihoods, that decrease criminogenic behavior, that improve the outcomes of unborn children. I mean, these is like everything that we would want to do. And it also happens to be the right thing to do on top of it. So I would say that as we build these systems and we start to put together how we do it, we will have bumps in the road. We will figure out, issues about stigma internally, about how do we screen, how do we pay for it, which meds do I use, how often do I dose it, how do I get my providers on board, how do I get nursing trained to dose the medications correctly, how do I get, make a decision between Sublocade or Vivitrol or Probufene or, Suboxone, Bunavail, Zubzol. I mean, all of those things, we have answers for these things. We have answers. So ask, and we will make sure and help you get those answers. But once we get this instituted and fully built into the California Department of Corrections and Rehabilitation, we are going to write all this up as kind of a how-to manual so that people can go to work on getting it done. But don't wait for that. There are basic things that can be done. There are grants available in California right now, the Quick Start grants that allow for support and help for that. I'm involved in that and do teaching and training around that. So I'm happy to connect you with the right person for that. It's Donna Strugard-Fritsch. She's been leading that for a long time. And so at this point, I think it's really important that we consolidate around the fact that it is going to be has to be the standard of care to deliver addiction treatment inside of prisons, inside of jails, inside of parole and probation, and any diversion program if we're ever going to really meet the needs of the communities in which we live. And I have a bunch of references for everything that we went through. And again, quickly preview the question. So any questions? So that's it. I mean, that's my soapbox. But I'll always kind of come back to it's the neuroscience that drives most of this stuff. So I'm happy to answer any questions you have. Feel free to type those in, and I will answer those. So it's your last chance for Stump the Chump. So bring it on. All right. I'd like to offer telehealth treatment for people in jail, but I think Medi-Cal is suspended while in jail. How do we cover it? That's a great question. So yeah, so it's a federal mandate that you cannot use Medicaid while somebody is incarcerated in jail. So the way in which you would have to do it is you would just have to cover on a per diem the person who does the telemedicine internally. So you would contract with a local provider to deliver telemedicine, and it would just come out of general fund. Unfortunately, but ultimately, if you have very high risk populations, that is the most cost effective way to do it. And typically you're going to be able to do that without a whole lot of cost per consultation required. And you can do a lot of internal work with the staff that you have and training them to the top of their license. And that would definitely be the best way to go about that one. Any other questions? Let's see. Is that it? Nothing fun? Nothing controversial or COVID related? Let's see what we got here. Let's see. I often hear jail staff say patients will divert buprenorphine in jail. This would be hard, but possible, and isn't a reason to withhold life-saving treatment. How would you respond? The answer is yeah, they're going to try to divert it. This is the disease of addiction. So the way that we decrease. So interestingly, in the jails and the prisons that have started this, what they found was early attempts to divert. But when they dug into the diversion, what they found was that it was being diverted because there was still demand from those that didn't have access to treatment yet. And once they identified everyone who needed treatment, nobody was really wanting to buy buprenorphine anymore. So if they didn't want treatment, they might still be buying heroin or using meth or other drugs, but the buprenorphine didn't become a commodity. An interesting aside to this is if you're in any place with long-term people, there are inmates who end up basically accumulating drug debt. And so they end up saying, look, I'll pay you later as soon as I get it. I'll pay you later as soon as I do it. And they build up a pretty solid amount of drug debt to the shot callers or the drug dealers internally. And so they lose privileging throughout. There have been a couple of prisons that we've been watching closely. And in one of those prisons, the prisoners had to work out, the prisoners with drug debt had to work out on the dirt, and those that did not could work out on the concrete. And over time, they actually saw the group of people on the dirt decrease down to just a couple from about 50 over time. And we thought that part of that was, one, the treatment is working, but two, they were probably diverting a portion of their treatment to pay off their drug debt. And so I had this philosophical quandary of like, I'm not sure what to think about that. While it breaks a rule in my head, like the person who's worked for police departments in my head thinks that's breaking a law, that's breaking a rule. And then I'm like, but now they don't have drug debt, so now they're not tempted to do what they're saying, and violence is decreased, and we're adding this. These are difficult things to struggle with. And but the big piece is that it's which drug you use. So using whether or not you use like Bunavail, which goes on the cheek, Zubsolv or Suboxone, making sure that it is delivered by nursing in the appropriate way, and doing it in a way that you are mindful that if they are labeled as being in treatment, sometimes the drug dealers will go after them. So you have to set this up in an appropriately HIPAA compliant way. And some people are doing this through differential jobs that they give, or just different times. They don't call it Medline. They pull them in at other times, or they put everybody in a single cell block or in a single yard that is on it so that they can put it together. So you have to be thoughtful of this, and then you'll significantly decrease the diversion of buprenorphine. But the number one thing that decreases diversion is identifying the supply, the people who are the demand folks, and then you won't have to worry about the supply side as much, because you'll get them treated and they'll be stable. It's a great question. Can you explain the Title II ADA reasoning? I've never thought of OUD as a disability, nor have I heard it referenced prior to today. Yeah, so ultimately, if you have an opioid use disorder is a neurobiological derangement which alters judgment outside of your normal capability of thought. So what that means is that if you have schizoaffective disorder and you have a hallucination and you act on that, that's still seen as a disability. And it's actually been written up by federal prosecutors in the state and District of New York, where they put it out there, but now there's also case law. So if you have diabetes and you need to leave your work site or leave your desk so that you can go and check your blood glucose and use insulin, then that falls within the Americans with Disabilities Act. It's a medical disease, just like addiction, which is also classified, and appropriately so, as a medical disease, and it's a medical brain disorder. And so because of that, if you take away, and specifically this was Title II, where it's talking about if you were withholding medical treatment for an identified medical disease, and ultimately that meets all the requirements needed for a Title II violation, since this is seen as a chronic neurobiological disorder, no different than the chronic endocrinological disorder that diabetes is. It's a great question. Anything else? All right. Well, it has been a real pleasure to speak to you guys. I appreciate all the questions and the input, and please, any feedback is always welcome. I always want to try to make these better, and in any way that you feel that it could be improved or delivered differently, I'm happy to hear it so we can make it better. But otherwise, please stay safe. And thanks again to Granite Wellness for putting this together, and Serenity and Shelley and the whole group that has done this. They've done a great job, and good luck with everything. And I'm sure we will somehow interact at some level. Have a great day.
Thank you, Dr. Waller, for this excellent presentation,
no problem.
along with all of the others. We appreciated collaborating with you.
No, it's been fun. No, I really appreciate it. And you guys have a good rest of the day. And I'm sure we will interact on the other side.
Sounds good. Thank you so much.
You bet. All right, bye.